This is part of a series I call the Making Evidence-Based Medicine Simple series, or MESS for short. In MESS Minis, we review an essential EBM concept. In this MESS Mini, we will discuss the performance of diagnostic tests that have continuous or ordinal results using receiver operating characteristic curves. Essentially, we use diagnostic tests or clinical decision rules that have a dichotomous result, for example, those with a positive and negative result, to allow us to stratify the patients into high and low risk categories. This is a standard 2x2 table that is used to calculate the test characteristics of a diagnostic test or clinical decision rule that has only two possible results. The disease goes on the top in the columns and is divided into those with disease and those without disease. The results of the diagnostic test or the clinical decision rule go on the side in the rows and is divided into positive and negative test or rule results. From the 2x2 table, we can then calculate the diagnostic test characteristics or rule characteristics that we are familiar with. These include sensitivity and specificity, predictive values of a positive and negative test or rule, and the likelihood ratios of a positive and negative test or rule. So how do we assess the performance of a diagnostic test or clinical decision rule that is not characterized as a positive or negative result, but can take on a range of values? For example, a diagnostic test such as a white blood cell count or temperature, which are continuous variables, or a clinical decision rule with a scoring system such as the pediatric appendicitis score, which is an ordinal variable. We have two options. We can use interval likelihood ratios or receiver operating characteristic curves. We will briefly touch on interval likelihood ratios, then spend the remainder of the talk on ROC curves. The first approach is to use interval likelihood ratios. Interval likelihood ratios are based on ordinal categories of the test. This table presents data from a study assessing the utility of the white blood cell count in the diagnosis of appendicitis. The white blood cell count was categorized into 5 intervals. Remembering that a likelihood ratio with a value of less than 1 indicates a decreased risk of the outcome, we can see that a WBC less than 8, from 8 to less than 10, from 10 to less than 12, are associated with a decreased likelihood of appendicitis. The likelihood ratios of white blood cell count from 12 to less than 15 and at least 15 are greater than 1, indicating an increased likelihood of appendicitis when the white blood cell count is in those intervals. It is important that these intervals are chosen based on the data and not arbitrarily assigned. The second approach is to use receiver operating characteristic or ROC curves. This is the most common approach. ROC curves can be applied to diagnostic tests with greater than 2 possible values, as well as clinical decision rules that utilize a scoring system such as the pediatric appendicitis score. ROC curves can be used to determine the test or rule's accuracy and its comparative accuracy to other tests, and the optimal cutoff point to use. An ROC curve plots sensitivity on the y-axis and 1 minus specificity on the x-axis. Since we typically don't think in terms of 1 minus specificity, it is helpful to label the axes as specificity with 100% specificity occurring at the junction of the x and y axes, and 0% specificity occurring at the distal end of the x-axis. When 1 minus specificity is equal to 0%, specificity is equal to 100%. When 1 minus specificity is equal to 100%, specificity is equal to 0%. It is also helpful to orient yourself to where an ideal test would fall on this graph. The star in the upper left-hand corner represents an ideal test with a sensitivity of 100% and a 1 minus specificity of 0%, which equates to a specificity of 100%. The star in the upper right-hand corner represents a test with a sensitivity of 100% and 1 minus specificity of 100%, which equates to a specificity of 0%. The star in the lower left-hand corner represents a test with a sensitivity of 0% and a 1 minus specificity of 0%, which equates to a specificity of 100%. Lastly, the star in the lower right-hand corner represents a test with a sensitivity of 0% and 1 minus specificity of 100%, which indicates a specificity of 0%. This is a truly dismal test. Ideally, a test or decision rule with high accuracy will be as close as possible to the upper left-hand corner, where sensitivity and specificity are 100%. Sensitivity on the y-axis can also be thought of as the true positive rate, or the percentage of patients with disease who had a positive test result. 1 minus specificity on the x-axis can also be thought of as the false positive rate, or the percentage of patients without disease that had a positive test result. Let's look at a line drawn at 45 degrees. At every point on the 45-degree line, the true positive rate is equal to the false positive rate. Essentially, if the test is positive, there is an equal chance of having disease and not having disease. This is equivalent to flipping a coin. This line also illustrates the trade-off between sensitivity and specificity. An increase in sensitivity can only occur with a decrease in specificity. An increase in specificity can only occur with a decrease in sensitivity. The accuracy of a diagnostic test or clinical decision rule is determined by measuring the ROC curve's area under the curve, or AUC. Test accuracy is a measure of how often the test is correct. That is, how often the test correctly identifies those with disease and those without disease. For the 45-degree line, the area under the curve is 50%, or 0.5. This is essentially a worthless test. In general, we would like the area under the curve to be greater than approximately 0.7 or 70% to be considered at least fair. In general, I am not a fan of using accuracy to describe test or rule performance. Accuracy is a composite measure of sensitivity and specificity. My issue with accuracy is that it assumes that sensitivity and specificity are equally valued. Ideally, you want both a high sensitivity and specificity, but that is not always possible. As the ROC curve illustrates, there is always a trade-off between sensitivity and specificity. In general, we prioritize sensitivity over specificity. The first row in the table indicates that when sensitivity is equal to 90% and specificity is equal to 90%, the accuracy is 90%. The second row in the table shows that when sensitivity is equal to 80% and the specificity is equal to 100%, the accuracy is also 90%. If only the accuracy is presented, then it is unclear what the sensitivity and specificity are. And since there are generally more patients without the disease in studies, the accuracy is weighted by the larger number of patients without the disease and thus is weighted towards specificity over sensitivity. Here's the data that we will use to construct an ROC curve. It is based on a hypothetical study assessing the utility of the white blood cell count in the diagnosis of appendicitis. Notice that if a white blood cell count above 0 was considered a positive result, all of the patients would be considered positive. It would correctly identify all of the patients with appendicitis and therefore would have a sensitivity of 100%. At the same time, it would classify all patients without appendicitis as positive so that the specificity would be 0%. For the bottom line, we'll assume that no one in the study had a white blood cell count of greater than 40. If a white blood cell count was greater than 40 was considered a positive test, then no patients would be considered positive. It would not identify any of the patients with appendicitis and therefore have a sensitivity of 0%. It would correctly classify all patients without appendicitis as not having appendicitis, resulting in a specificity of 100%. Obviously, we'd like to choose a test value somewhere in between those extremes. Here is the data from our hypothetical study plotted as a receiver operating characteristic curve. Notice that the 0 white blood cell count starts at the top of the curve. A white blood cell count of 0 has a sensitivity of 100% and a specificity of 0%. The white blood cell count greater than 40, if indeed no patients had a white blood cell count greater than 40, has a sensitivity of 0% and a specificity of 100%. We can then calculate the area under the curve. In this example, it is 0.75, which is considered fair test accuracy. We can also add a curve for another diagnostic test or rule to compare its accuracy to that of the white blood cell count. In this example, we add a curve based on hypothetical data for C-reactive protein in appendicitis. We see that the area under the curve for C-reactive protein is 0.9 or excellent and is greater than the area under the curve for white blood cell count, which is 0.75 or fair. We can conclude that CRP is a more accurate diagnostic test for appendicitis than the white blood cell count. There are also statistical tests that can be used to determine if the difference in the areas under the curve is statistically significant. After determining that the white blood cell count is an accurate predictor of appendicitis, what white blood cell count cutoff would you select? In general, we would select a point on the curve where there is an inflection point. An inflection point is a point on the curve when there is a decrease or flattening of the slope of the curve. A decrease or flattening in the slope of the curve indicates that for a small increase in sensitivity, there is a large decrease in specificity. In this example, the inflection point occurs at a white blood cell count of 10. As a reminder from high school math, the slope of the line is the change in y divided by the change in x. For an ROC curve, the change in y divided by the change in x is the change in sensitivity divided by the change in 1 minus the specificity. In moving from a white blood cell count of 10 to a white blood cell count of 0, 10% increase in sensitivity and a 40% decrease in specificity for a slope of 0.25. In moving from a white blood cell count of 20 to a white blood cell count of 10, there is a 10% increase in sensitivity, but only a 30% decrease in specificity for a slope of 0.33. This indicates that there is a greater change in sensitivity for change in specificity when moving from a white blood cell count of 20 to a white blood cell count of 10 than there is in moving from a white blood cell count of 10 to a white blood cell count of 0. Based on this, our optimal cutoff point is a white blood cell count of 10. For white blood cell count less than 10, we have decided that there is an unacceptable decrease in specificity in relation to a small increase in sensitivity. In our table of hypothetical study data, a white blood cell count of 10 had a sensitivity of 90% and a specificity of 40%. For extra credit, what does the slope of a line drawn as a tangent to a point on the ROC curve indicate? The slope of the line is the change in sensitivity divided by the change in 1 minus specificity. Where did we see that formula sensitivity divided by 1 minus the specificity before? The formula sensitivity divided by 1 minus the specificity is the formula for a likelihood ratio of a positive test. The slope of a line drawn tangent to a point on the ROC curve is the likelihood ratio at that test value. In summary, interval likelihood ratios, or ROC curves, are used for diagnostic tests that have a range of outcomes and clinical decision rules that utilize a scoring system. The area under the curve is used to measure the accuracy of the diagnostic test or clinical decision rule and can be used to compare it to the accuracy of other tests or rules. Finally, ROC curves can be used to determine the optimal cutoff point for a test or rule.